Welcome, everybody. Good afternoon. I just have to apologize. There was some communication glitch, probably my fault, but the title of my talk is actually Percutaneous Ventricular Assist Devices 101. And given the time constraints, this is truly a 101 introduction to percutaneous ventricular assist devices. And I've got nothing to disclose, whatever that means. All right, simply defined, percutaneous ventricular assist device is a percutaneously placed mechanical pump or device that supports a failing ventricle. Most commonly, these are designed for left ventricular support, although there are RV support devices as well. And these are designed for very short-term use only. A percutaneous ventricular assist device is indicated in the presence of acute decompensated heart failure, acute MI with or without cardiogenic shock, in protection for a high-risk PCI, and in shock following open heart surgery. The most widely used today percutaneous ventricular assist devices are, of course, the intra-aortic balloon pump, the Impella by Abiomed, the Tandem Heart by Cardiac Assist, and of course, ECMO, which is made by several manufacturers. This is just a cartoon of those four devices. It's hard to see, but from the left, intra-aortic balloon, the Impella, the Tandem, and ECMO, and I'm going to talk about each one individually in a moment. More than 230,000 patients are supported every year by percutaneous ventricular assist devices, and of these, as many as 70% are with the old-time favorite, the intra-aortic balloon pump. But the use of Impella is growing rapidly, and believe it or not, ECMO is also increasing in use. So first of all, our favorite that's been around forever, the intra-aortic balloon pump. As we all know, it's a balloon-tipped catheter that's placed in the descending aorta. It inflates during diastole, deflates during systole, displacing blood both antegrade and retrograde, and it's been in use since 1968. This is just a cartoon showing the balloon properly placed in the descending aorta. On the left is a picture of the deflated balloon. On the right is the inflated balloon, and I don't know if you can tell, but on the right you can see the coronaries are engorged with bright red oxygenated blood as blood is forced back into the coronaries with inflation. The benefits of intra-aortic balloon pumping are, of course, the increase in coronary and systemic perfusion. It should decrease your LV work, preload and afterload, and you'll see some reduction in myocardial oxygen consumption. This is just a reminder of that waveform we're all so familiar with, just to remind you that the timing has to be pretty precise. If the timing is off, at best, you're not going to help the patient, and at worst, you can actually do more harm than good. The components of the IABP are very simple. We have the pump console that contains the helium that inflates the balloon, and the catheter itself. On the left, of course, is the console. On the right is the balloon. The advantages to using an intra-aortic balloon over other devices are that it's delivered through a relatively small arterial puncture. It's now 7 French or less. The manufacturers have made timing of inflation and deflation almost idiot-proof. It's rare that the user has to tweak the timing at all. It's inserted through a very familiar femoral artery puncture, and it can be done at the bedside. You don't need fluoroscopy to place an intra-aortic balloon pump. The disadvantages are, of course, that the effectiveness is dependent on absolute precise timing of inflation and deflation. You have to have some degree of native LV function. If the LV is in really bad shape, the intra-aortic balloon won't be able to do much to support it. And it really provides inferior hemodynamic support when compared with other devices, and you really only can get marginal flows of like half a liter per minute. Of course, it's contraindicated in the presence of an aortic dissection, in the presence of severe peripheral artery disease, and of course, if the patient has aortic insufficiency, you're just going to make that worse with every balloon inflation. Which brings me to our next device, the Impella, and I'm only going to focus on the Impella 2.5 because that's the device we predominantly use here at Sinai, and it's right now the device of the Impellas that's most commonly used. It's known as the world's smallest heart pump. It's FDA approved in cardiogenic shock, as well as protection in high-risk PCI. It's described as a catheter-based axial flow pump that pulls oxygenated blood from the left ventricle and then expels this oxygenated blood across the valve into the ascending aorta. By doing this, it mimics the blood flow of the natural heart. The benefits, of course, of Impella therapy include decreased LV volume, decreased left ventricular and diastolic pressure, myocardial oxygen demand, and ventricular workload. And you also have an increase in your mean arterial pressure and cardiac output. The components of the Impella 2.5 system include the console or brain, known as the AIC, the catheter itself, a connecting cable to connect the catheter to the controller, and the purge system. On the left is a picture of the console. On the right is a blow-up of the distal end of the catheter. This is a picture of the catheter properly placed in the left ventricle. I don't know if you can see the inlet area where the blood is withdrawn into the catheter sits right in the middle of the left ventricle, and the outlet area is just on the other side of the aortic valve in the ascending aorta. This another picture of the device itself. I just wanted to show this one because the little inset on the left shows the tiny little motor the impeller that draws in and drives this device. The advantages to Impella therapy, of course, is that it's placed by a very familiar insertion technique again. It can be set up in about 20 to 30 minutes, not as fast as an intra-aortic balloon pump, but faster than other therapies. And it provides much superior support over an intra-aortic balloon alone with flows up to 2.5 liters per minute. The disadvantages to Impella, as well as to intra-aortic balloon, is that they're designed for very short-term use. Now, the Impella can stay in place as long as 4 days, and I actually read that they're stretching it even higher, but it's really intended for short-term use. This little impeller motor can damage red blood cells, causing hemolysis in as many as 10% of patients. And, of course, it requires access to the left ventricle, which means you have to cross the aortic valve. It's contraindicated, of course, if the patient has the presence of left ventricular thrombus, if he has a mechanical aortic valve, severe aortic stenosis, again, very severe peripheral artery disease, or in the presence of a ventricular septal defect. Which brings me now to the Tandem Heart, which is described as a two-catheter-based left atrial to femoral artery bypass system. And the way it works is that a catheter is placed across the atrial septum into the left atrium, withdraws oxygen-rich blood out of the left atrium, and then returns it through a return catheter through the femoral artery into the arterial system. The benefits, by directly unloading the left atrium and thereby the left ventricle, you'll decrease LV preload, LV workload, and myocardial oxygen demand, and you're going to increase your cardiac output and your mean arterial pressure. The components of the Tandem Heart include the transeptal cannula, the pump itself, the return arterial cannula, and the control console or the brain. On the left is the console. The inset is a picture of the pump itself without the cannulas attached, and on the right is a cartoon of the pump secured to the patient's thigh with the venous catheter going up the IVC into the right atrium, across the atrial septum into the left atrium. That's where it withdraws blood into the system by the pump, and then deposits it back into the arterial system as oxygenated blood, obviously. On the right is a picture of the transeptal or left atrial cannula. I don't know if you can tell, but it's not a small cannula. It's a fairly sizable cannula, which is going to create a fairly sizable hole in the patient's atrial septum at 22 French. It's not small. And on the left is the arterial cannula, which is also not small at 15 to 16 French. Again, that's the picture, the cartoon of it on the left, and on the right is a picture of what it really looks like and what the patient has to kind of put up with while they're undergoing tandem heart therapy. It's obviously a lot cleaner and prettier in a cartoon. The advantages of using the Tandem Heart are that you can leave it in place for up to 10 days, or as short as hours, but you can leave it in for much longer than the other two devices. It doesn't require access to the left ventricle, so you don't have to cross the aortic valve. And you can get flows up to 4 liters per minute, which is pretty substantial hemodynamic support. The disadvantages of using the Tandem Heart is that, of course, transseptal puncture is required, and a lot of interventionalists are, quite frankly, not that comfortable with transseptal puncture. They don't do it every day. And that hole that's created to get to the left atrium can persist, leaving a not so small atrial septal defect that may require the patient to come back for another procedure to deal with, to close. Because the cannulas are sizable, the patient has to be over 40 kilos to be considered for Tandem Heart therapy. And honestly, the placement is pretty cumbersome and time-consuming. It's not something you wouldn't be able to do, suddenly in an emergent situation. Tandem Heart therapy is contraindicated, of course, if you've got right atrial or left atrial thrombus, again, severe peripheral artery disease, or if the patient is profoundly coagulopathic, you certainly wouldn't want to use this device. And that brings me to the last, ECMO. I think most of us think of that as a bad 4-letter word because it just makes us all sort of weak in the knees. It's understandable because it's reserved for our very sickest patients, but it's actually kind of a great device. And I predict we're going to see more use of it. In fact, in 1990, less than 100 were placed, and in 2015, over 6,500 were placed. Anyway, what does it stand for? The 4 letters: extracorporeal membrane oxygenator. The 2 main types of ECMO, and the first is the one that I'll deal with. You can have veno-arterial ECMO, which provides both hemodynamic as well as respiratory support, and veno-venous ECMO, which only provides respiratory support. How does veno-arterial ECMO work? So a venous cannula takes deoxygenated blood from a vein, from a central vein, and pumps it into an oxygenator to get oxygenated and to remove CO2. And then this oxygenated blood is returned to the arterial system. Of course, the patient benefits because they will get full cardiopulmonary support, and you can achieve flows up to 6 liters per minute with ECMO. The components are deceptively simple. You have a venous cannula, you have the pump itself, and then the oxygenator that takes care of the gas exchange, and then you have the arterial cannula to return this newly oxygenated blood to the arterial system. This is a nice little drawing, making it look so simple. This is not the configuration you would use in an adult, but the blue line coming out of the patient's femoral vein indicates the blue venous blood being drawn by the pump through the oxygenator and then into the artery. And now it's oxygenated, nice red blood being brought to the arterial system. In adults, you wouldn't put it in their carotid artery, probably more like the femoral artery, but they do this in children with this configuration. This is more likely the configuration you'd see in an adult with a cannula in the right IJ, drawing the venous blood into this lovely little oxygenator and then returning it to the femoral artery. And I don't know why people don't love ECMO, because it looks so simple, right? But no, this is actually what it really looks like. It's not quite as compact as the cartoons show it to be. This is a later model, not the latest model, but it's pretty much what they look like. This is, in fact, a picture of one of the ECMO consoles that we use here today at Sinai. Not so portable, not so easy to run. It's pretty complicated. It does a great job, but it's got a lot of moving parts. The advantages of veno-arterial ECMO are that it allows for therapy as long as weeks, if necessary. This is the only percutaneous VAD that provides both hemodynamic and respiratory support. And believe it or not, you can place ECMO at the bedside in an ICU. It doesn't need fluoroscopy. And since its greatest use has been in infants and children, it's designed for small people, so it can be in any size patient, child, adult. The disadvantages, of course, are that it's very complicated and labor-intensive to set up and maintain. You pretty much have to have a perfusionist available or present 24/7 while the patient is getting ECMO therapy. And it's not the perfect therapy for some of our adult ischemic patients because by dumping this big volume of blood into the arterial circulation, you're actually going to cause increased ventricular afterload and causing increased myocardial oxygen demand. The other distinct disadvantage to ECMO is that this is a close-up of what it really looks like. It's labor intensive. It's complicated. Anyway, this is just an overview. These are the 4 devices. There are going to be more of them being designed, and they are being designed every day. As our population continues to live longer and longer with more comorbidities, the use of these devices is going to just grow. I predict, especially in the near future, we'll see more and more use of the Impella. All of these devices, including ECMO, are going to become more streamlined and user-friendly. And I predict that one day the use of percutaneous ventricular assist devices will become standard of care when taking care of our high-risk PCI patients and patients in cardiogenic shock. Thank you all, and enjoy the rest of the afternoon.